Chapter 16 is drug therapy for high blood lipids or cholesterol levels. So cholesterol, it's a fatty, waxy material that the body needs to function. Cholesterol is produced by the liver, and it's also in foods that we eat. Our body uses cholesterol to produce hormones, vitamin D, and bile acids that help us digest fat. The body only needs a small amount though. Too much in the bloodstream can lead to narrowed arteries like in atherosclerosis and coronary artery disease. The chemical form of most of the fats in the foods and in our body is triglycerides. Cholesterol and triglycerides are in the blood. These two equal plasma lipids. A high level of the plasma lipids or blood fats called hyperlipidemia can lead to atherosclerosis, coronary artery disease, hypertension, pancreatitis, peripheral vascular disease, stroke, and xanthomas, which are these abnormal fat deposits throughout the body. Atherosclerosis is a major contributor to the development of coronary artery disease. It begins by forming a fatty streak on the arterial wall, leading to a fat buildup or plaque. Fat buildup on the walls of the coronary arteries can result in partial or complete blockage of the blood flow to the heart muscle. The main lipids involved are cholesterol and triglycerides. Partial blockage in the coronary arteries can result in chest pain called angina, while complete blockage can cause a heart attack or myocardial infarction. So we have HDL and LDL. The good cholesterol is HDL or high density lipoproteins. You can remember that by thinking the good cholesterol is high density lipoproteins, and I want that number to be high. HDL is necessary to help remove other forms of cholesterol from the blood. It absorbs it and carries it back to the liver, and the liver flushes it from the body. Then we have LDL. This is the bad cholesterol. It's low density lipoprotein. So remember that by low density lipoprotein, I want that number to be low. Too much can lead to the problems that we just talked about. So anti-hyperlipidemics work against the high levels of lipids in the blood. We use them along with dietary changes like eating less fat to lower cholesterol. Some of them work to decrease the production of cholesterol in the body and increase the ability to remove that LDL or bad cholesterol. Some reduce the amount of fat that the body absorbs from food. Some promote cholesterol loss in the stool. So lipid-lowering drugs are used most often to treat high blood lipid levels that fail to decrease with lifestyle changes like reduced fat diets, increased exercise, smoking cessation, and weight loss. When lifestyle changes don't result in lower blood lipid levels, the patient remains at risk for development of heart disease, especially in the presence of other risk factors like hypertension and diabetes. Before we give any anti-hyperlipidemic drugs, we have to get a complete drug list, including herbal and over-the-counter drugs. We need to know if women are pregnant or plan on becoming pregnant or breastfeeding. We need to know histories of liver and muscle problems. And after, we need to monitor liver labs and for symptoms of liver damage like jaundice, dark urine, light-colored stool, and muscle damage like soreness, pain, and weakness. And we teach our patients about continuing those lifestyle changes, following up with their labs, and that treatment is lifelong. There are 5 main types of lipid-lowering drugs. We have statins, HMG-CoA reductase inhibitors, bile acid sequestrants, cholesterol absorption inhibitors, nicotinic acid agents, and fibrates. So statins first, these lower the blood lipid levels by slowing the production of cholesterol and increasing the ability of the liver to remove LDL cholesterol from the blood. They don't increase HDL, they just lower LDL. Side effects are usually mild and disappear as the body adjusts to the drug. They include upset stomach, gas, constipation, abdominal pain, and cramps. One of the adverse effects is rhabdomyolysis, which is a muscle breakdown. Signs and symptoms of that are general muscle soreness, muscle pain and weakness, vomiting, stomach pain, and brown urine. It's caused by the small reddish-brown pieces of broken down muscle that are removed from the body through the urine. Statins can also cause decreased liver function. Because of this danger, liver function tests should be performed regularly, like every 3 to 6 months. Before I give statins, I want to know their baseline kidney function. I want to know if they drink alcohol, And I want to continue to monitor liver function, and for muscle breakdown, I want to monitor urine output, BUN, and creatinine levels, because those are your kidney function tests. Statins should not be given to patients who consume more than 2 alcoholic drinks a day, because drinking alcohol puts even more stress on that liver. Remember, we have our general stuff for all anti-hyperlipidemics. These are just specific to statins. Teach your patients to take these exactly as prescribed and to avoid grapefruit and grapefruit juice. Safe use of statins in kids under 8 has not been determined. We really only use it occasionally with older kids that have a family history of high cholesterol. Statins are contraindicated with pregnancy and breastfeeding. Fat is necessary for brain development in the fetus and infant. When there's not enough fat in the body during pregnancy and infancy, the fetus can suffer poor brain development and mental retardation. So we're really not going to use it with pregnancy and breastfeeding. In older adults, they're considered safe as long as there's no history of muscle problems or myopathy or liver disease. Then we have bile acid sequestrants. These help the body lose cholesterol by binding with cholesterol in the intestine, preventing the fats from being absorbed, then eliminating the cholesterol from the body through the stool. The intended response here is to decrease LDL and actually increase HDL. Side effects are GI related, since these work with the GI system to remove fat through the stool. So you'll see like GI discomfort, nausea and vomiting, constipation, and gas. Adverse effects are an increased action of warfarin. Lots of drugs do this, okay? They also inhibit the absorption of fat-soluble drugs and vitamins, which makes sense because they inhibit fat absorption in general, so it includes these fat-soluble drugs and vitamins. Bile acid sequestrants can inhibit the absorption of other drugs, so they should not be given within 2 hours before taking other drugs or 4 to 6 hours after. We also want to see if there's any problems with constipation, because these can cause constipation. After, we want to assess for constipation and other GI issues like bloating, gas, nausea, and vomiting. If the patient takes warfarin, we need to monitor closely for signs of bleeding and monitor INR, which we'll talk about more in chapter 20. Some signs of bleeding are easy bruising, clammy skin, paleness, dizziness, increased heart rate, decreased blood pressure, shortness of breath, and confusion. Teach the patient to take those other drugs, like I said, at least 2 hours before and 4 to 6 hours after taking a bile acid sequestrant. Take them with plenty of water to prevent any sort of bowel obstruction. Take them with meals to absorb intestinal cholesterol. It's important that they are taken with meals to absorb that cholesterol. In kids, we want, cholestyramine and cholestyramine should not be used because they can cause such severe constipation that they end up with a bowel obstruction. We don't use colesevelam in kids either because its safety hasn't been established. Bile acid sequestrants are fairly safe in pregnancy, but colesevelam's safety hasn't been established for pregnancy and breastfeeding either. But overall in pregnancy, we probably don't want to lower cholesterol anyways, because that fetus needs a constant level of cholesterol for brain development. Next, we have cholesterol absorption inhibitors. These drugs work to reduce the amount of cholesterol that's absorbed by the body. We use them when a low-fat, low-cholesterol diet doesn't work, and when patients can't take statins because of their side effects. The intended response is to decrease LDL and the total level of cholesterol. Some common side effects are GI issues again, like stomach pain and diarrhea, not constipation here. Other common side effects include fatigue, back pain, joint pain, rash, and sinusitis. Adverse effect is angioedema. Again, that's swelling beneath the skin, usually around the eyes, nose, and lips, caused by blood vessel dilation. That can be life-threatening when it affects the airways. Before I give it, I want to know if they have liver disease, muscle disorders, so I'm going to check their liver function tests. Also check, because with use of this drug may worsen liver disease if it's prescribed along with a statin. Some signs of decreased liver function are decreased appetite, fatigue, jaundice, weakness, or muscle problems like aches and pains. I want to monitor the patient for decreased liver function, fatigue, abdominal pain, and again, that facial swelling or angioedema. Teach them to report any muscle pain or tenderness or weakness. Take once a day at the same time, because that helps the habit helps the patient remember to take the drug and helps make the timing of any intestinal symptoms from the drug more predictable. And call 911 if there is angioedema. In kids, the safety in kids younger than 10 has not been established, so it probably wouldn't be used. Safety has not been established in pregnancy and breastfeeding. We don't know if it's excreted into the breast milk, so we would really only use it if the benefits outweigh the possible risks. Then we have fibrates. Fibrates decrease liver production of triglycerides and increase the use of triglycerides by the fat tissues for metabolism. Fibrates also increase cholesterol excretion in the bile, which can lead to the development of cholesterol-based gallstones. So they activate the cell lipid receptors and break down lipids for elimination. The intended response is decreased triglycerides and a mild increase in HDL cholesterol. Side effects are mild, like stomach upset, diarrhea, GI issues, muscle weakness, headache, pruritus, which is itching, and a rash. Some other common side effects are related to GI issues as well, like indigestion and heartburn. Patients could also experience muscle weakness, headache, bleeding potentially. Adverse effects is that it can increase the creatinine levels in patients with kidney disease, and it can also increase the effectiveness of warfarin, so it can lead to excessive bleeding. When we give these, I want to know if they have a history of kidney, liver, or gallbladder disease. I want to know if they're taking warfarin. I want to know their baseline kidney and liver function tests. I want to monitor their for indications of issues with the kidney, liver, or gallbladder. If they're taking warfarin, I want to monitor for bleeding and monitor their numbers as far as that goes, and then follow-up tests with for their kidney and liver function. I want to teach them to avoid grapefruit and grapefruit juice because it interferes with the metabolism or breakdown of the fibrates in the body, making them less effective. I want to teach them to take these 30 minutes before meals, avoid heavy alcohol, and again, avoid grapefruit and grapefruit juice. Report signs and symptoms of bleeding, especially if they're taking warfarin. They should not have more than a couple alcoholic drinks a day. In pregnancy and lactation, there's a moderate risk for birth defects or fetal damage. Fibrates can cross the placenta and affect fetal brain development, so we're not going to use them. In older adults, if they're taking warfarin, they're at a greater risk for bleeding problems, so they need to monitor for bleeding and keep up with their appointments to monitor INR. And then last, we have nicotinic acid agents. Nicotinic acid is a special type of B vitamin that helps decrease triglycerides, total cholesterol, and LDL, and then also increase HDL. Side effects here are some GI issues such as nausea, indigestion, gas, vomiting, diarrhea, and abdominal pain, but also include some other stuff that's specific to niacin, like itching, nasal inflammation, and dilated blood vessels. Patients can also experience flushing or redness and hot flashes, chills, dizziness, fainting, headaches, a rapid heart rate, shortness of breath, sweating, and swelling because of fluid retention. Adverse effects include liver toxicity. Gout can happen because of a buildup of excess calcium, hyperglycemia, stomach ulcers. So before I give it, I want to know their baseline vital signs and liver function tests. I want to know their glucose levels for diabetic patients, if they have a history of liver disease or diabetes, and their usual alcohol intake. I want to continue to monitor their liver function tests and vital signs and glucose levels. Nicotinic acid can increase blood glucose levels in diabetic patients, so doses of the drugs used to control the blood glucose might need to be adjusted as well. And if they do have flushing and hot flashes, they can use aspirin about 15 to 30 minutes before they take the nicotinic acid. Teach your patient to start with low doses and gradually increase, but again, that's going to be something that the provider does. We're not going to, increase their doses without the provider's guidance. Notify the provider if there are any side effects, and take these with meals. Again, teach them that if they have hot flashes and flushing, they can use aspirin or an NSAID before they take the medication. In pregnancy and lactation, there's a moderate risk, so we would avoid it during pregnancy and lactation. And that is it for Chapter 16.